Good day, everyone, and thank you for joining us today for our webinar, Reversing DOACs, Providing Answers on Why, When, and How. Please note that we are recording this symposium. I am delighted to be joined by distinguished faculty members, Dr. Erik Klok from Leiden University Medical Center in Leiden, the Netherlands, Dr. Geoff Barnes, University of Michigan in Ann Arbor, Michigan, and Dr. Allison Burnett, University of New Mexico Hospital in Albuquerque, New Mexico. And I'm Dr. Deborah Siegal, Associate Professor at the University of Ottawa in Ottawa, Canada. Here are the learning objectives. We thank Actelion Pharmaceuticals Incorporated for their support of this webinar. This activity was jointly sponsored by the ICH and the France Foundation. To claim credit, be sure to evaluate this symposium. This is the agenda for today. After some introductory remarks, Dr. Klok is going to be discussing DOAC reversal agents and start with a framework on how to think about managing DOAC-associated major bleeding. Followed by that, there will be two case presentations by Dr. Barnes and myself that outline the principles of management. And finally, Dr. Allison Burnett is going to present about system conversation with important system and stewardship aspects of DOAC-related bleeding management. This will be followed by a panel discussion, including question and answers from the live audience. So thank you for completing our misconception questions with your registration. We asked these questions, and here are your initial responses. By the end of this session, it is our hope that you will confidently answer these questions. The first question was as follows: in the event of a severe or life-threatening bleed in a patient treated with a DOAC, the anticoagulant effect of the DOAC cannot be reversed. Is this true or false? And you can see here that the majority of respondents indicated that this is in fact false. The second question was, which of the following is true in the event of severe life-threatening bleeding in a patient treated with a DOAC? And the majority of respondents indicated that if DOAC-specific assays are not available, then additional considerations, including the type of DOAC, the timing of the last dose, and the pharmacokinetic properties, in addition to routine coagulation tests, can be used to assess the likelihood of clinically significant levels of DOAC in the patient. And then finally, for patients with DOAC-related bleeding, which is the first and most important management step, here the majority of respondents identified that assessment of the severity of bleeding, including a hemodynamic assessment, was in fact the first and most important management step. And now I'm going to pass the microphone to Dr. Klok for his discussion of DOAC reversal agents.
Thank you, Deb. It's a true pleasure to be here. I'm very exciting hour and a very important topic which we deal with virtually every day in our practice. So a few slides on what do we actually know about reversal agents and the management of major bleeding. So a few key questions that we'll be answering during this hour actually are lined up here. So how can we estimate whether the bleed is severe? What kind of supportive measures are relevant? How should we deal with the potential of oral anticoagulants? Can we measure it? Should we reverse it, and how should we reverse it? And very importantly, and this is often forgotten in this discussion, is that even at the moment you're considering reversing the effect of the oral anticoagulant, you should have some thoughts on how to restart this. Because if this is forgotten, it may end up causing harm to our patients. All right, when I talk to my fellows about treatment of major bleeding, I teach them the 2 rules of 3, and I hope you bear with me and you may find those useful for your own practice. And the first rule of 3 is first things first. This I tell my kids as well, but this is another point. And the first thing we have to do in a patient with a major bleeding is to establish hemodynamic support. Very important, because if you do not establish this, the patient may die. It may not always be necessary, but it's relevant to make sure that it happened. Second step is to look for possibilities of achieving local hemostasis. Again, very relevant and should be done even before we start thinking of reversal anticoagulant treatment. This is the third step. So if you have taken action to support hemodynamic situation, if you have taken action to achieve local hemostasis, then we can consider reversal of the anticoagulant effect or any hemostatic therapies. The second rule of 3 is think twice when you're considering anticoagulant reversal. The first thing you have to do is to confirm relevant anticoagulant drug effects. The easy thing to do is talk to your patient, but this is not always possible, and ask the patient which kind of drug he takes, how often he takes it, and when the last dose was taken. If it's impossible, there are ways to use the laboratory to check whether there's a relevant drug effect, and we'll talk about this in much more detail in the case discussions. So if you have established the fact that there is a relevant anticoagulant drug effect, then we need to assess whether or not we need to reverse the drug. And there are not guidelines on this, but there is actually some common sense criteria that we have to apply. So this is obvious in cases of life-threatening bleeding, but also relevant to situations where there's a bleeding in a critical organ or critical site, situations where it's impossible or we failed in achieving local hemostasis, and in cases where there's supratherapeutic anticoagulation. So in those 4 circumstances, roughly in those 4 circumstances, we can consider reversal, the effect of drugs or any hemostatic therapy. And finally, if we are at the point that we decide that we want to reverse the anticoagulant drug, we have to choose the optimal agent. It must be effective, it must be available. So the answer to this may be different in different hospitals or countries or regions. But these are the possibilities that have been used and are mentioned in guidelines. So prothrombotic concentrate, adurosazumab for dabigatran, andexanet for rivaroxaban, apixaban, activated PCC, and Novo7 has been mentioned earlier on in guidelines, but has been removed because it's largely redundant now when in the situation where we have andexanet. So the question is, why do we have to go to all this trouble to give hemostatic drugs or anticoagulant reversal to patients? Well, there are 2 main reasons. The first one is that the prognosis of anticoagulant associated major bleeding is poor, even if you are able to completely reverse the anticoagulant effect. So the first steps, making sure that there's hemodynamic stability and support, and trying to achieve local hemostasis is possibly or probably far more important than giving patients hemostatic drugs or reversing their anticoagulant agent. And finally, anticoagulant of the reversal strategies are often costly and may cause harm to the patient. For instance, patients may have a higher incidence of blood clots, arterial or venous, in the days after we treat them with any hemostatic drug. So these things we have to keep in mind when we look in our practice to patients. With that in mind, we move to the patient cases we have prepared, and let's see if you can bring those 2 rules of 3 into practice. So up to you, Geoff.
Thank you so much. And Dr. Klok, you did a great job laying the foundation for what we're going to talk about here in these next 2 cases. So we're going to dive into a little bit of the data as well as apply sort of the framework that was just outlined to think about how to clinically manage these patients. So let's start with our first case. This is a case of a 72-year-old gentleman. We'll call him Harry. He takes dabigatran for stroke prevention in atrial fibrillation. Now, he comes into my emergency department with some bloody stools for the last 3 days. It started with some streaking of blood on whenever he would have a bowel movement, but in the last day, he's noted some blood even in his undergarments, despite not having bowel movements, and this really got him concerned. On that box on the left, you can see he does have a past medical history of hemorrhoids, as well as hypertension and obesity. In the middle box, you can see the medications he's currently using. He takes dabigatran 150 milligrams twice a day. He also uses lisinopril, atorvastatin, and he's on aspirin. So he is on 2 antithrombotic agents. Now in the rightmost box, you can see his vital signs. His heart rate is normal at 89 beats per minute. His blood pressure is also normal at 134/76. When we look at his laboratory studies, his hemoglobin level is 120 grams per liter. That's down from a prior lab of 134. His hematocrit has similarly fallen from 43% to now 36%. And his creatinine level has risen. It's currently 168 micromoles per liter as compared to a prior lab, which was 124. But that still puts him in a reasonable renal function range with an estimated creatinine clearance of 62 milliliters per minute. So as Dr. Klok outlined, the first question we need to ask ourselves is, how severe is this bleeding? Is this a major or a life-threatening bleed? Well, let's ask some of those key questions. Does he show any evidence of hemodynamic instability? No, he came in, he's talking to us, he's got a normal blood pressure, a normal heart rate, his hemodynamics are stable. That's good news. Second, does he have clinically overt bleeding? Yes, he's showing signs of clear bleeding, but has he had a 20 gram per liter hemoglobin drop? Or in some parts of the world, we might say a 2 gram per deciliter hemoglobin drop, depending on your lab values. Or has he required any red blood cell transfusion? And right now he hasn't. He hasn't quite had that big a drop yet. So he would get a no for that as well. And then the third question we ask ourselves, is he bleeding into a critical organ such as the brain, the central nervous system, something like that? Thankfully, he's not. He's currently having bleeding in his GI tract. So this is somebody who is not having a critical, life-threatening, or even a major bleed at this point. Now, Dr. Klok outlined a nice framework for thinking about the severity of bleed. This is a different way of looking at the exact same information. This is a graphical representation. On the left side, you'll see non-major bleeding events. These are often the smaller bleeds. Maybe it's a bruise or a dental bleed. Maybe it's a nosebleed or a hemorrhoidal bleed. But these are bleeds that don't reach the threshold of achieving a major or life-threatening bleed. But of course, more severe bleeding could put you into that major category. Perhaps you could have a major bleed, but it's not quite life or limb threatening. That might be something like a hemodynamically stable GI bleed or a posterior nosebleed. And then of course, the most severe would be a life-threatening or a limb-threatening, organ-threatening bleed like intracranial hemorrhage or bleed that causes significant drop in hemoglobin. And so there's this spectrum of bleeding. And importantly, I want you to look at the bottom of the screen. We must continue to reassess our patients because they can change. It's not just how they initially present, but what happens to them over time may change their severity and therefore how we treat them. Now, if you have a patient who has a non-major bleed, that's in green, we will often be able to continue their anticoagulant, but we're really going to focus on those local measures. So we think about getting some lab studies and then make sure that we're locally monitoring and supporting that patient as they get through their bleed. If you move into more of the major but not clinically life-threatening bleed, that's where we're going to interrupt the oral anticoagulant, use local measures like compression, volume replacement, and perhaps if this is a patient on a vitamin K antagonist, we'll even give some vitamin K to try and reverse some of that activity. And then for our most severe bleeds, those are the ones in red, that's the life-threatening bleed. This is where we start to think about reversal. So we've heard about things like vitamin K or prothrombin complex concentrates, PCCs. You heard briefly about idarucizumab or even andexanet alpha, and we can think about some of those elements. Now, one of the questions that's commonly asked is this person taking an anticoagulant, and is the anticoagulant impacting their bleeding risk? Dr. Klok outlined this question. Many of us who trained back when vitamin K antagonists were the predominant oral anticoagulant are used to getting a rapid PT or INR test. Unfortunately, with the direct oral anticoagulants, we just don't have a rapidly available lab test that can tell us whether this person is anticoagulated or not. Our standard thrombotic tests like the PT-INR or the PTT are just not reliable across the board. If the patient takes dabigatran, you can think about a thrombin or dilute thrombin time, or maybe you have access to a specialized test called the Ekerin clotting time. For the factor Xa inhibitors, you really need to look at an anti-factor Xa assay. Many centers don't have these as drug specific. They may not be rapidly available, so it's somewhat limited. In that case, it's important that we do exactly as Dr. Klok said. We need to talk to the patient and ask them questions. So let's go back to our case of Harry. We talked to Harry and we found out his last dose of dabigatran was taken about 6 hours ago. So it's likely to be clinically important for this patient. We got some routine coagulation tests. His PT was 11.2 seconds, an INR of 1.2, and an APTT that was slightly prolonged at 34 seconds. But importantly, we made sure to continually reassess him. And over the course of 4 hours, we saw that his presentation got more significant. The heart rate that was 89 became now 110 beats per minute. The blood pressure that had been 134 systolic now dropped to 106 over 62. He's now showing us signs that he's having more hemodynamic compromise because of this bleeding event. In fact, we repeated his hemoglobin and found that he's now at 102 grams per liter. That's a significant drop from where he was before. And that fits with the fact that he continues to bleed without having bowel movements. So at this point, we made a decision to get more aggressive. Obviously, we held his anticoagulant, we held dabigatran, but we also got our gastroenterology colleagues involved. We gave intravenous fluids to support him. And we said, should this patient get some advanced therapy like an endoscopy? And then we also had to ask ourselves whether or not some further therapy beyond just red blood cell transfusion is needed. So let's talk about our two specific reversal agents for the direct oral anticoagulants. On the left side of the screen, you can see idariacizumab. This is a humanized antibody fragment that's really meant to target just dabigatran. That's its one main target and drug to use. It's a non-competitive binding that's been clinically tested and approved in two important situations. The first is patients who need an urgent surgical procedure, but the second is patients like Harry who are having life-threatening or uncontrolled bleeding. It's pretty easy to administer. It's a one-time 5-gram IV bolus that's given. And thankfully, it's pretty widely approved and available in North America, in the European Union, the UK, and in many other places across the globe. Now, the other direct oral anticoagulant specific reversal agent is andexanet alpha. That's the right side of your screen. This is a humanized recombinant factor Xa variant. So it looks a lot like the factor Xa inhibitors, and it has competitive binding. So it pushes those factor Xa inhibitors off of factor Xa. It is currently tested and approved for use in reversal of apixaban or rivaroxaban in the setting of life-threatening or uncontrolled bleeding. Now, it does have some variable dosing depending on which drug and how recently that drug has been taken. So you have to be really careful with the dosing there. But it has been approved and is available for use in the United States, the European Union, and the UK. Currently not in Canada, I believe. And there are, importantly, some ongoing randomized trials for intracranial hemorrhage use there. So it's not got quite as broad a use as idariacizumab, but it does have some good quality data behind it. We'll get into some of that in a minute. Now, of course, Harry, our patient, was taking dabigatran. So let's look at some of the data around dabigatran reversal. And this comes from the Reverse AD study. In this, there were two groups of patients. Group A had uncontrolled bleeding. Group B had an emergent surgery or procedure. All of them received 5 grams of IV idariacizumab. And what you can see in the figures here is the rapid reversal, the rapid normalization of the unbound dabigatran levels. That's the graph on the left, and the APTT test, which is on the right. And thankfully, those stayed fairly consistently low for 12 and even up to 24 hours. So plenty of time to try and address the source of bleeding. In fact, hemostasis was achieved in more than 2/3 of patients within 24 hours. A mean time to hemostasis, 2.5 hours in patients who had extracranial bleeding. So for Harry, what should we do? Well, in this case, he's having evidence of ongoing bleeding. He's now hemodynamically unstable. This is where we need to get aggressive. So in addition to the fluid resuscitation and all, we gave him 5 grams of IV idariacizumab. He was transfused 2 units of red blood cells, and our gastroenterology colleagues came in and performed a flexible sigmoidoscopy to find some bleeding diverticulum, and that was felt to be the source. Of course, once all this stabilized, we have to ask an important question. He was taking this drug for stroke prevention and atrial fibrillation. Should we restart dabigatran? And if so, when should that happen? Well, we have some data from a meta-analysis, and this is actually a study Dr. Siegal was involved in leading, looking at patients who had GI bleeding, whether or not they resumed or did not resume their oral anticoagulant. And notably, almost half of patients didn't resume their anticoagulant for up to 3 months. So it's pretty common that people say one major bleeding event and I'm done with anticoagulation. But I'm gonna just summarize this real quick. If you do resume the anticoagulant, you have a 2-fold increase in the risk of recurrent bleed, but you have a 70% reduction in the risk of thrombosis and about 50% reduction in mortality. So overall, there does seem to be benefit from resuming anticoagulants after the bleeding source is stopped. Now, we need to caution that this was a meta-analysis of some pretty low quality, all observational studies. And so we don't have that high quality prospective study yet to really guide management. So in summary for Harry, the important lessons here were we needed to assess and reassess bleeding severity, looking at the hemodynamics, whether or not transfusion was needed and the location of the bleed. We needed to see how he responded to our local treatments. Once he became clinically unstable, we needed to give him idarucizumab, which is our dabigatran specific reversal agent. And then we need to think about when we should reinitiate anticoagulation for him because it has the potential to prevent future thrombosis and mortality. So I'm going to turn now over to Dr. Siegal, who'll walk us through our next case.
Thank you so much, Dr. Barnes. I'm going to continue our discussion of anticoagulant-related bleeding with this case of Glenn. And Glenn is an 86-year-old male who was assessed in the emergency department after he was found to be somnolent and had some focal neurological deficits by his retirement home staff. So he's taken to the emergency department where an urgent CT scan of the head shows acute hemorrhage in the basal ganglia, specifically the putamen. And it's important to note that Glenn's medical history is significant for atrial fibrillation, for which he receives apixaban 5 milligrams twice daily. He also has a hypertension, a previous TIA, and a history of coronary artery disease with a prior NSTEMI, and that was over 10 years ago. He's, in addition to apixaban, as you can see in the middle box, he's taking aspirin 100 milligrams daily, again, dual antithrombotic therapy here, which is important for us to think about, and we'll talk about that in some subsequent slides and hopefully in the discussion. Ramipril and atorvastatin. Overall, he's hemodynamically stable. His laboratory studies show he's not anemic. He's got a normal platelet count. His coagulation tests here are within the normal range, and that's important considering what Dr. Barnes has already told us is that these routine coagulation tests may not be sensitive to pick up clinically significant levels of the DOACs, including apixaban. He also has a normal renal function here, which is helpful for us to understand a little bit about whether or not he has clinically significant levels of drug. So if we return to this scheme of bleeding severity, we can see that that Glenn really presents with a bleed that's on the right-hand side of the spectrum in the red box. He has an intracranial hemorrhage, parenchymal bleed here, which is, of course, a source of high morbidity and mortality in these patients, and therefore we really want to make sure that we're optimizing management ASAP. And so the priorities for acute hemorrhage stabilization in the setting of intracranial hemorrhage, including the following ABCs taken from this very good review article referenced on the bottom of the slide. The first thing to do is to assess alertness and of course address any possible mass effect. The second step here is to optimize blood pressure, which is an important component of this management, which is to maintain blood pressure between 120 to 160 millimeters of mercury. And finally, this is where we come in today, is to correct the coagulopathy if it's present in a patient taking an anticoagulant. So these recommendations are to reverse the anticoagulant effect using a fast, effective agent if it's available. And so again, one of the most important principles here in bleed management, which was mentioned by Dr. Klok and then by Dr. Barnes, is whether or not the DOAC is present in significant quantities to cause a hemostatic defect. And in the absence of having specific laboratory tests to be able to measure this, and actually also a specific therapeutic ranges, it's really important for us to understand the time of the last dose and some of the properties of the drugs themselves in order to understand whether or not there are clinically significant levels present. And the important part of this slide that I want to highlight is the row on renal clearance. And of course, dabigatran here is the most renally cleared at about 80%, and apixaban the least renally cleared at about 27%, but they are all renally cleared to some extent. There may be important drug interactions that can affect the level of DOACs, and it's important to do a comprehensive medication review. And then finally, the half-life here is really important to understand whether or not the patient is likely to have DOAC on board. And so you can see here that the half-lives range between 10 and 17 hours, the most for dabigatran. Apixaban here, half-life around 12 hours. So we really need to understand when Glenn took his last dose. And as you can see from the slide here, Glenn took his last dose 6 hours ago. So in fact, if we recall that the peak effect of apixaban is about 2 to 4 hours after taking a dose, and the half-life is 12 hours, he is really likely to still have clinically significant levels of drug on board. And that's important for guiding future management. So if we return to this slide about specific DOAC reversal agents, we look towards the right-hand side of the screen where we've summarized andexanet alpha. Again, this is a decoy molecule that neutralizes factor Xa inhibitors and is available in some places, but not all. And so it's important to know which agents are available at your particular institution that can help you guide therapy. This slide shows the results of the ANNEXA-4 study. The ANNEXA-4 study was the study that led to approval of andexanet alpha for major life-threatening bleeding in patients receiving apixaban and rivaroxaban. This was a single cohort study in which patients who had acute major bleeding, that was adjudicated by a committee, actually, to ensure that all the patients were eligible for inclusion. If they had received their dose within 18 hours of presentation, they were eligible for enrollment into the study. And you can see here that they received andexanet by intravenous bolus and then followed by a 2-hour infusion. And of course, as Dr. Barnes mentioned, the dose of the drug really was dependent on what type of DOAC they took and when they took it. And you can see on the right-hand side of the screen that the administration of andexanet, by the end of the bolus, there was a dramatic reduction in anti-factor Xa activity, that was maintained throughout the duration of the infusion, and that 82% of patients who were enrolled in this study achieved good or excellent hemostasis. And again, this was adjudicated by an independent committee using a priori specified criteria that were actually specific for different bleed types. I should also mention that over 2/3 of the patients that were included in this study had intracranial hemorrhage. This is pretty relevant to our case and to Glenn's care. But what's important to keep in mind is, in addition to the benefit that people may derive from these agents, is the adverse events. And this may also be related to the timing of antithrombotic restarting, as Dr. Barnes mentioned. And you can see here, we've summarized the results of the reverse AD study. Of course, that was the idarucizumab study in ANNEXA-4, just to give you a sense of the risk of thromboembolism after patients have received reversal agents for major bleeding. And what's important to note is that these patients are presenting with acute major bleeding complications. They are on an anticoagulant, which of course is to prevent thrombosis from an underlying prothrombotic disorder. They've had their anticoagulant withdrawn. Their coagulation system is activated to achieve hemostasis, and now they're critically ill, perhaps in the intensive care unit. All of those factors contribute to the development of thromboses after the event. And so you can see here that the rates of thrombosis were somewhat variable, 5% in reverse AD and 10% in ANNEXA-4. And what I'd like to highlight is that something that Dr. Klok talked about, which is that anticoagulant-related bleeding really does carry a risk of adverse outcomes. And you can see here that the risk of death, or the frequency of death in these patient populations, was 13 to 14% within 1 month of presenting with these bleeds. And that's very important, not only for us to ensure that we are optimally managing these bleeding events, but also to counsel patients regarding bleeding and to prevent bleeding events in the clinic where we have the opportunity to do so. And finally, I wanted to mention here the importance of antithrombotic restarting in these studies. In ANNEXA-4 in particular, about 2/3 of patients started some type of antithrombotic. We don't know what type. That would include parenteral agents. And then only 1/3 of them had restarted oral anticoagulants by 30 days. Similar numbers in reverse AD, although again, by 90 days, 3/4 of patients, majority, had started some type of anticoagulant. Again, we don't know which one, and we don't know what dose. So what about the scenario, which is common to a lot of us, including me in Canada, where we don't have access to a specific reversal agent of andexanet, is the treatment of these bleeds with hemostatic therapies like PCC. This slide summarizes the results of a few prospective studies which were conducted of patients presenting with acute major bleeding on apixaban or rivaroxaban, and they were managed according to institutional protocols, and their medical records were reviewed to look for outcomes. And you can see that the treatment that was given here was 4-factor PCC. The average was 2,000 units. One study here looked at activated PCC at a dose of 25 to 50 units per kilogram. There is a lot of uncertainty about the optimal dosing strategy for PCC in this context. Some advocate a fixed dose of 2,000 units, and others will use a weight-based dose, such as 50 units per kilogram. There is a lot of uncertainty about which is optimal and the different effects of both. You can see here in these studies that hemostasis was achieved in the majority of patients, and that's determined using criteria that were established by ISDH, and that there was a risk of thromboembolism after these events, which varied somewhat across studies. The lowest was in the Majid study. But what you can also see is there really is a high rate of death in these studies, up to 32% in the Majid study. And this just speaks to the severity of these bleeding events. And of course, it's difficult to compare these studies because they're head-to-head. They lacked control groups. So again, what's important to understand here is that methods to support and treat our patients who present with acute major bleeding will help to prevent these bad outcomes. But again, I want to emphasize the limitations of the data here, which means that there's uncertainty about the incremental benefits and harms of reversal strategies, including our daricismab and andexanet, and hemostatic therapies like PCC. We really don't know if there's incremental benefit with respect to hemostatic efficacy. We don't know if there's incremental harm with respect to thrombotic events and mortality. And so this is really important for us to know going forward, and there's a lot of opportunity here for future research. So let's return to the case of Glenn, who had an acute intracerebral hemorrhage. Again, we're addressing the correction of his coagulopathy. He took his apixaban 6 hours prior to his presentation, and he was treated with andexanet using the low-dose strategy, 400 milligrams bolus, followed by 400 milligrams IV infusion, because that was available at his institution and was part of his institutional bleed management protocol. And so I want to kind of summarize this case by reflecting on the management of Glenn and other patients with anticoagulant-related major bleeding, and propose that this is really part of a spectrum of comprehensive anticoagulant care, which includes some of the principles listed on this slide, ensuring that the patient is treated for an appropriate indication, ensuring that laboratory testing is done and monitored, taking special attention to medications, including antiplatelet therapies. Both of the patients that we presented today were on concurrent antiplatelet therapies, and that really does need to be readdressed. In fact, the vast majority of patients likely do not require both types of antithrombotic therapies, but it's important to ask the question about why and to ensure that proper monitoring is underway. It's really important to make sure that the patient is on the correct dose for their indication and their clinical characteristics. And then finally, education and counseling is key. In the case of Glenn, of course, he recognized that there was some bleeding happening and he knew when to seek medical attention, really important. And then finally, routine follow-up and ensuring that that takes place is critical. And so the tricky question here is, of course, when do we restart anticoagulants and how? And there's a lot of uncertainty about this, and with a lack of high quality randomized trial data, of course. And what I want to show with this slide is that really one size does not fit all with regards to restarting anticoagulants. It's really important to think about these principles. Has the bleeding stopped? And what was done to stop the bleeding? Was it an intervention? Is there an ongoing indication for an anticoagulant? Because if there isn't, it should be discontinued. And then finally, weighing these thrombosis and bleeding risks is really critical because not all thrombotic risks are the same. with regards to absolute risks and also with regards to clinical consequences. And then similarly, not all bleeding risks are the same, even with respect to different categories of bleed. So intracranial hemorrhage is quite different than GI hemorrhage. And even among the different intracranial hemorrhages or GI hemorrhages, there's differences with respect to the severity and outcomes of those bleeds. And finally, all of this really needs to be done in the context of a shared decision-making framework where patients are engaged in order to help make the decision that's right for them. And so with that, I'd like to just summarize some of the key points that we've raised with Glenn, the patient with intracranial hemorrhage on a factor Xa inhibitor, and the importance of assessing bleed severity to ensure that supportive management and monitoring are in place. It's very critical to assess the likelihood of clinically significant DOAC levels, just as we discussed with Dr. Klok and Dr. Barnes. This is a really important principle of management. Anticoagulant effects should be reversed if the specific agents are available and if the bleed is life-threatening. And then additional therapies like hemostatic therapies can be given if andexanet is not available. This is, of course, something that's advocated by various guideline groups. And again, we don't have randomized trial data to know whether or not one strategy is more beneficial than another. And finally, that these patients really need to be managed using a comprehensive approach to restarting anticoagulants and ongoing treatment. And so with that, it's my pleasure to pass the mic over to Dr. Burnett for her presentation.
Well, thank you, Dr. Siegal. It's an honor to be part of this faculty panel and to be part of this important discussion. It's very clear that management of DOAC-associated bleeding requires thoughtful, methodical approaches. And this has become even more complex in recent years with the availability of multiple DOACs, multiple management strategies. And that complexity combined with the high acuity of these patients and the often hectic nature of these clinical situations really necessitates the need for standardized system-level approaches to best support both the patients and the clinicians. Thus far in the presentation, you all have done an excellent job of laying out important information that helps us think about why and when we may need to reverse the direct oral anticoagulants. And so I thought it would be helpful to also discuss how hospitals can take this important information and translate it into clinical practice through use of standardized system-level approaches and stewardship elements that can facilitate best practices around DOAC-associated bleeds. Because there are multiple pharmacologic agents that can be used in this clinical setting, hospital, pharmacy, and therapeutic committees have to come to consensus on which agents are going to be available for use in the hospital. And having awareness of the institutional rates of DOAC-associated bleeds can be very helpful because it can help hospital administrators anticipate budget impact, and it can also help pharmacy administrators know what type of inventory levels they're going to need to stock. These DOAC bleeding events can be identified in a number of ways. They can be identified in real time by some type of triggering clinical event tied to an electronic alert, or perhaps even more simply, they can be identified retrospectively through clinical and diagnosis codes. If these data query processes haven't been established and aren't in place, that's obviously going to require some time and effort. But this really should be viewed as a high value investment because these queries can also be used longitudinally for ongoing stewardship efforts, as well as continuous quality improvement. And when hospitals are considering formulary addition of hemostatic or reversal agents, it is absolutely critical to involve all of the key stakeholders that are going to be using and managing these agents. And these stakeholders need to have a high degree of familiarity, not just with the most recent clinical data, but also the practical management aspects around each of these modalities, because that information needs to be used collectively to answer these questions of formulary adjustments, prescribing restrictions, And also it empowers those individuals to effectively participate in protocol development. Now, curation of this type of key input group can also take time and effort, but your return on investment here is that once you identify and engage these individuals, that promotes a culture of shared stewardship across the organization. So high functioning stewardship relies very heavily on these system level standardized approaches, and they need to be customizable to the individual patient need, and they need to span the continuum of care from the moment that patient presents all the way through discharge. And in regards to DOAC associated bleeding, most hospitals are going to have some type of controlled access over these hemostatic and reversal agents for both cost reasons and also because, as has been mentioned, they could be potentially harmful. But this controlled access has to be carefully balanced with rapid access to these agents when they are indicated. And societal guidelines and accreditation bodies here in the US strongly encourage embedding standardized evidence-based protocols into the workflow. And these protocols really need to have a high degree of clinical decisional support that's going to make it easy for prescribers to do the right thing and difficult for them to do the wrong thing. So an ideal protocol, for example, would direct a prescriber to select the appropriate dose of andexanet for apixaban reversal rather than potentially selecting idarucizumab, which is not only going to be ineffective, but also represents a significant waste of resources. The pharmacists that are responsible for verifying these orders are another highly effective means to promote stewardship. And when they're involved, they need to be well supported in a culture that allows them to take a few moments to speak with the ordering prescriber to make sure that protocols are being adhered to and that reversal is absolutely indicated. Every step of the medication distribution process needs to be engineered so that it minimizes turnaround times, costs, wastes, and also dosing errors of these agents. And so some examples include fixed dose PCC, efficient admixture of andexanet alpha, and also things like delivering idarucizumab in unopened boxed kits to the bedside so they can be returned to the pharmacy for credit if they're not used. Continuous quality improvement is one of the major components of stewardship. And again, this can be accomplished through use of those established data queries that I mentioned on the last slide. And the metrics that institutions can follow are things like adherence with protocols, adverse events, and they very much should consider using these for feedback to both clinicians and hospital administrators in regards to areas for potential improvement in performance. And very, very importantly, there has to be strong focus on transitions of care for any patient that was on a DOAC requiring reversal for a major bleed. As Dr. Siegal's research shows, the majority of these patients should be considered for resumption through shared decision-making. However, the hold times are often prolonged and can actually be pushed into the next care setting. So we clearly need to have standardized processes that promote documentation, communication, and an effective handoff of the agreed upon resumption plan. And, you know, embedding things like templated language or reminder prompts in the EHR can greatly support clinicians so that they don't have to remember to document these important pieces of information. Anytime we have a patient in whom it's deemed not appropriate to resume anticoagulation, we need to be very mindful of considering alternative modalities. For example, left atrial appendage for our atrial fibrillation patients, simply so they don't go, you know, unprotected against thromboembolic events in perpetuity. Okay, Benjamin Franklin is very famous for saying an ounce of prevention is worth a pound of cure. And I can't think of any other situation where that is more applicable than anticoagulant associated bleeding. And it is very true that the best way to manage a bleed is to prevent it from happening in the first place. The DOACs represent a major evolution in the therapeutic landscape, but as we've seen, they're not devoid of adverse events. And I think that often this is driven by the fact that they're not held in the same regard as vitamin K antagonists because they don't have to be monitored, they're more convenient. And this can lull clinicians into a sort of set it and forget it mentality that really puts our patients at risk. So we need to remain diligent in routine follow-up of these patients. And I would suggest in a specialty anticoagulation clinic, so these agents can be optimally managed. I would also suggest that we are routinely monitoring for and managing any type of adverse events and continually assessing for any needed changes to our patient's anticoagulation regimen. So in summary, reversal is just one part of bleeding management. And by far and away, prevention is the first and foremost effective strategy. So be thinking about those things like Dr. Siegal mentioned, concomitant antiplatelets, concomitant NSAIDs, also things like optimizing blood pressure, and whenever possible, in appropriate patients, switching them from a vitamin K antagonist to a direct oral anticoagulant. Anytime a bleed does occur, protocolized management that includes early interventions and supportive measures and possibly reversal is absolutely essential. But equally essential is consideration for resumption of anticoagulation once that bleed has resolved. The anticoagulation is still indicated and the patient is amenable to resumption. With that, I will turn it back over to Geoff Barnes.
Dr. Burnett, thank you so much. That was really a great summary of the systems we need to support this clinical decision-making. So I'd like to now open up to our panel discussion. We have a couple great questions that have come in from the audience. Dr. Klok, I'd like to start with you. There's been a question asking about the term anticoagulant-associated bleeding. Is it the anticoagulant that causes the bleeding, or is it some other mechanism that causes bleeding and just anticoagulation maybe impacts how long or how severe the bleed is? How do you think about that?
Yes, thanks, Geoff. It's almost a philosophical question, right? Because normally, if our blood vessels are intact and there are no endothelial problems, then there cannot be leakage of blood. So for me, an anticoagulant drug may increase the amount of blood loss, may increase the severity of the bleed, but it does, of course, not cause disruption of the blood vessels. Of course, many patients take blood thinners without any bleeding events, which is a testimony to this. I once was in a presentation where the presenter told us that the only way for anticoagulant drug to cause a bleeding is when it's loaded in a gun and shot at the patient. But now it's probably not that black and white, but normally it only increased the severity of the bleed.
Wonderful, thank you. Yeah, I've heard that phrase before. It's dramatic, but I think it gets to the point. Dr. Siegal, I'd like to ask you a few questions, and this really gets to andexanet alpha and the half-life of, or the effective half-life of that drug. You know, you talked about in the Annexa 4A study where you give that initial bolus and then you have an infusion for a few hours. Can you help us understand if that infusion is only lasting a few hours, why or how are we assessing hemostatic efficacy all the way out at 12 hours? And how should we think about that half-life of the infusion and the drug as far as, you know, finding ways for the bleeding to resolve? How do we piece all that together?
Thanks so much for that question. So this is, of course, an important issue related to the way that andexanet works and also related to the half-life of the DOACs, which we know in patients with normal kidney and liver function is around, let's say, 12 hours, kind of ballpark. So the idea is that a patient is actively bleeding, their own coagulation system is activated. Now the drug has been withdrawn and their own coagulation system is activated to achieve hemostasis. Once administration of andexanet happens, then of course the drug level is rapidly decreased. And so that allows an opportunity for the native hemostatic mechanisms to take place. So ostensibly, hemostasis is achieved by removing the anticoagulant effect, which we've heard, again, I agree with Dr. Klok, increases the severity of bleeding. And so during the acute bleed setting, admittedly, yes, once the infusion is discontinued, we've seen in different studies that the DOAC levels increase again by around a few hours after the infusion is discontinued to where we would expect they would be just from clearance of the DOACs themselves. So the idea again is that right during that period of active bleeding, we're enhancing hemostasis by removing the drug in order so the native mechanisms can take place. I think one of the things that this highlights to me is the challenge again of understanding the incremental benefit that can be achieved with these agents because we don't have a control group to know whether or not there was what the extent or what the incremental benefit we could see here. So we really look forward to the results of the randomized trial in which andexanet is compared to standard care to be able to see if those effects are enhanced in patients receiving andexanet. So point well taken.
Really important data, I think, that we need to be generating here in the future. Another question, and this one I'm going to pitch to you, Dr. Burnett. You talk about the importance of having a protocol to really make sure that in these critical situations, people know what they're doing. They know how to give the right drug, the right dose. When we talk about DOACs, there's often a lot of discussion about weight and whether DOACs are appropriate given different weights. Are there the same considerations for DOAC reversal? Do we need to think about weight when we pick a reversal agent or a dose, or is it really based on the drug and the time since last injection? How do you protocolize or operationalize that at your centers?
All right. Well, thanks for that question, Dr. Barnes. First, I think that, obesity doesn't come into play when we talk about dosing these agents for reversal. I think you're exactly right in your latter point that we need to stick to basing this on the half-life of the drug, the patient's renal function, which agent they're on, and the time from last ingestion. Obese patients haven't been studied adequately in this space, so we don't have any information to inform us to do anything different than what these agents are labeled for. Now, I say that in regards to andexanet and idarucizumab, but as Dr. Siegal mentioned, there are a large variety of dosing strategies for prothrombin complex concentrates. So systems that use that as a reversal strategy may encounter this question of obesity. And I believe in the package insert for Kcentra here in the United States, they actually max out the dose at 100 kilos. And when you're using 50 units per kilo, that would be 5,000 units. And I believe that is to mitigate the prothrombotic risk. So really, I think the only time that would come into play would be with prothrombin complex concentrates.
Great, that's really great advice and thinking about all our different reversal strategies. Dr. Klok, I'd like to turn to you with another question. We've talked a lot, especially in these two cases, about bleeding and patients having a major or life-threatening bleeding, but what about the patient who needs an emergent surgical procedure? We got some data about that in the idarucizumab study, but that was not necessarily studied for patients in Annexa 4, where we used andexanet alpha. Can we use andexanet alpha in a sort of a pre-emergent surgery situation? If you do use that off-label, do we have to worry about then being able to use heparin during the surgery? I mean, what's some of the advice you would have about the emergent surgical situation?
Yes, so from a European perspective, it's off-label and guidelines recommend against it because it's not tested. I'm not sure if you should have any concerns about the effect of heparin. Well, of course, especially if you give infectionated heparin, but guidelines I recommend against because of the lack of evidence. It's the same for applying an extant alpha to patients with bleeding on edoxaban or low-molecular heparins. So it may work, but it has not been studied. So I would recommend not using it for that reason.
Yeah, no, I think that's the same. We certainly don't use it at my center either. Dr. Siegal, I'd like to turn to you, and this might be our last question as we're running up at the end of our hour. You really highlighted the importance of assessing the resumption of anticoagulation after a bleeding event is controlled. And there's a number of questions asking, well, when do you do that? How quickly do you resume? Do you jump right back into maybe that full dose anticoagulant, or do you use a lower dose and step them up? Do you have just a couple of thoughts that you could share with the group?
Thanks so much for this question. This is actually occupies a lot of my clinical and research time answering this question. So I'd like to say stay tuned for more high quality data, but the way it stands right now is that there isn't a one size fits all approach, and perhaps that sounds a bit overreaching, but I think what's really important here is to think about restarting anticoagulation and then initiating the process whereby, understanding why the patient bled, where they bled from, what was done to address the bleed. And then on the thrombotic side, what thrombotic event are we trying to prevent is really important. And again, not all bleeds are the same. So this requires interdisciplinary care. It's important to, liaise with the gastroenterologists or the neurosurgeons or the neurologists to help answer this question. As you dive more into the specific details of different bleeds and different bleed mechanisms, there really are a lot of differences in terms of not only the absolute risk of something happening, but also the consequences of that happening. So for example, we don't have high quality data to tell us exactly when to restart and exactly what to restart. But I think, a thoughtful management approach includes the patient and also is iterative over time. So the patient is reassessed over time. And that's sort of where I would say we actually put together a nice document for the American College of Cardiology. There's a bleed management working group, and there's an app with some considerations of how to think about restarting anticoagulation, understanding that we don't know what strategy carries the most benefit and minimizes harm. But certainly in the clinical setting, if someone's in hospital, often you will see the use of perhaps low doses or prophylactic low-molecular heparin in the short term and escalating those doses to being mindful, of monitoring for consequences. But in the outpatient setting, it can be more tricky as Dr. Burnett mentioned, those responsibilities are often pushed to the outpatient setting, and that's where the communication piece is really important. So there's no one size fits all approach. I wish I could say more, and maybe in a few years' time we will.
Well, thank you for that summary. There are many questions. We could do a whole nother hour of just Q&A, but I want to thank everyone for joining us today. All of the participants. I want to thank Dr. Siegal, my co-chair, Drs. Burnett and Klok, my fellow presenters. Thank you to ISTH, the France Foundation, Alexion for supporting this symposium. And we hope everyone has a great rest of your ISTH meeting.